So welcome to Write the Knowledge Wave 3. It's our pleasure to have you, and we are looking forward to a great session. So in this session, we are not only riding the knowledge wave, but we are also shifting sands. And we do that with 5 fantastic speakers from all over Europe. So this session will be all about the organizational setting of implementation. So you will hear about leadership, about interprofessional processes, about organizational culture. So Eva Angelini will start off the session. Eva is a research nurse at Sahlgrenska University Hospital in Gothenburg in Sweden, and she will talk about the challenge of identifying and facing organizational culture and resistance to change prior and during structural change. Afterwards, we will hear Alvaro Sanchez from Basque Country in Spain, and he is a research associate at the Primary Care Research Unit of Biascaya and also affiliated to the Basque Healthcare Service Osakidecha. He will talk about optimizing type 2 diabetes prevention through interprofessional collaborative processes. He will be joined by 2 speakers from the UK, Dr. Jo Day. She is a research fellow at the University of Exeter, and she will present findings from a systematic review on the impact of management and leadership styles on implementing changes in long-term care. And then followed by Dr. Tom Jefford. He is the director at Family Psychology Mutual and a former long-term EIC board member. Tom will talk about the implementation of multi-systemic therapy through English local government services and how this is influenced by the role of leadership and environmental context. And the wrap-up of today will be done by Dr. Tekla Brumkert. She is a postdoctoral researcher at University of Basel, and she will provide you with a deeper understanding of the implementation of a pain management guideline in Swiss nursing homes. So you will really be all over Europe in very different organizational contexts. We have 5 speakers, so we are quite tight in time. So we encourage you to please put your questions in the chat. If there are many questions, we will try to answer them along the talks in the chat. And after each talk, we will take 1 or 2 questions. So to take not more time from the speakers, I would give the word right away to Eva.
Thank you.
Enjoy.
Thank you. Can you hear me?
Yes.
Great.
Perfect.
Thank you. I hope my microphone will keep the whole way. Okay. As I got the theme for this session, Shifting Sands, Tackling the Organizational Setting of Implementation, honestly, I needed to go shifting sands. Maybe I'm not the only one. I don't know. Anyways, that was really interesting. So I found a lot of stuff on the net, and I got these ones. Shifting sand refers to something that is constantly changing, often making a person feel uncertain, or something that is very unpredictable, or changes that happens with time. Since we're here talking about healthcare, I think this is very suitable. The origins of shifting sands are many. One of them that I liked was that it's likened to the sand running through an hourglass. We say time glass in Sweden, but anyways, as the time goes by, more and more sand runs through the hourglass, and this indicates that everything changes with time. So I think this is a very suitable theme for a session like this, as healthcare is very shifting in today. And I hope my presentation can contribute to the challenging task of implementation in healthcare. I can have my first slide, please. What I forgot to say is that my presentation is part of my dissertation that I defended and is published in February this year. And it's entitled Postoperative Pain Management in Planned Lumbar Spine Surgery and Implementing Structural Changes in a Complex Healthcare Setting. So this is it. This is the background. These three pictures is a way for me to explain the background. Most of us will have low back pain during our lifespan, 1, 2, or 3 times. I don't know, depends on who we are. And not all of us will undergo surgery, but some of us will. And if we do, we will be treated in a healthcare organization. And these organizations are often submitted to production demands and stress. Furthermore, there is a wait for surgery in Sweden as well as in many other countries. And this wait affects the person in pain and his or her conditions and surroundings. I can have my next slide, please. So this slide, thank you, Leah. Good. This is a lot of animations on this slide, so we'll just keep our fingers crossed. Anyways, as you can see, there's this timeline that stretches over a number of years from 2016 until 2020. And you can see there is a pre-post intervention on the title under design. Pre-intervention, co-creation period, and post-intervention. I think you can click like 3 or 4 times now, Leah, please. That's it, thank you. So during the pre-intervention, this is what it looks like. Let's see what we had in this unit. And the unit that we're talking about is the setting. It's a spine surgery unit at a large university hospital in Western Sweden. And both patients, adults and children are treated, both trauma, oncological patients and elective spine surgery patients. That's our setting. Albeit this study focused on non-oncology and elective lumbar adult patients. So that's our setting. Then we got setting, we got the timing, and the aim of the study. Didn't I give to you? I think I'll give it to you. I'll give it to you later. So this is the beginning. This is what it looks like before we did an intervention, pre-post intervention. So overall, there were no care plans concerning pain. There were no written discharge summaries to the patients once they were operated and going home. And there was an inadequate and unsure round routine. So that was the first part. Now you can click like 1, 2, 3. Sorry, back off. 1, thank you. So this is the intermediary timing, so the co-creation period. And we have a multi-professional, local expert with different professions, as I said, and researchers creating something that would respond to the prior usual care that I just explained. And then we can take the rest of the clicks, please. Thank you. And this is the period, the post-intervention, where the implementation were responding to what was co-created. And what was that? That was care plans for all the patients. There were admission interviews, person-centered with the patients before planned surgery. There were written care plans when they got out of they were going home, and there were a clear round routine implemented during this session. And the last click for this slide, please, is that what we're going to talk about today. So I wanted to give you an overview of the bigger research project, but this is what we're talking about today. And the orange squares are the different studies we've made, and the ones we're talking about today is the last ones encircled in black here. Okay, thank you. We can take the next slide. Yeah, good. So the aim of this study was to describe the impact of an implementation of a systematic change process concerning postoperative pain and person-centered pain management. And we were interested in resistance to change and organizational culture during the time that I just explained to you in the previous slide. And the method was quantitative. We used the survey which contained 2 validated questionnaires. So resistance to change. Healthcare organizations can develop fatigue and are frequently faced with organizational change. Sometimes we talk about this resistance as individual, but can also be seen as from the context in which the change takes place as a bigger organization resistance. And that was what we were measuring with one of our instruments in the survey. So let's take it. The instrument we used was the resistance to change scale. And you can see here, it takes up 4 areas within resistance to change: routine seeking, emotional reaction, short-term focus, or cognitive rigidity faced to a change process. So let's look at the results for this part of the survey, please, the next slide. Here you can see on the first row, RTCS, and that's the mean of the resistance to change. And then we have the different areas, which I just talked about. So please click 4 times, I think.
Just flagging that you have 2 minutes left.
Oh, thank you. You can go back so that we can look at that one. So what we see here is that we're slightly descending on resistance to change over time on mean and all the different areas. Okay, let's take the next slide. Another part of the survey was the organizational culture. And that's based on the competing values framework, which you can take and click, and the 2 next clicks too. The competing values framework is just competing, as we are saying. And there's 2 forces, internal and external, and flexibility and control. And there's competing, as you can see, as the flashes showed here, on diagonals. And there's a good thing to have when you are changing something in healthcare or any organization for that sake, to have a little of both, so there's a balance of these different culture types. So we did this survey also, and we can look at the results in the next slide. We have clan, autocracy, market, and hierarchy. Those are the different culture types that we're going to look at. Okay, the next slide, please. So in the pre-intervention and the post-intervention, this is what we had. This is what the results. What's interesting here is that you can see a red line going, and you can see a green one, because when you take this survey, you actually fill the survey out twice. The first time is how you see your culture in the current situation. And then you fill it out another time, and that's when you fill out how you prefer that your culture would be, and that's the green dotted line here. So what's interesting here, that's in the pre-intervention, the left diagram, you can see that it's the red one, the current one, is pretty square, but there is a hierarchy, market dominance on the right bottom left. And when we look on the post-intervention, that dominance on the current, the red one, is slightly going over to hierarchy, to internal side. What's interesting is that the green one is consistently pointing up to the left side, which is the clan culture. And the clan culture is a very familiar culture where the ward or the unit is like a big family where we take care of each other. So these are the results in organizational culture. So we can see that it's pretty stable over time, because there was a persistent amount of time, about 2.5 years, as you saw on the timeline earlier. So let's take the, I think I'm just gonna now take some, I'm gonna take and give you some, wrap it up and see what my reflections or take-home messages are. So the clinical relevance and the purpose of the current study within quality improvement is that implementation of change needs to be combined with structural as well as the relational aspect of change. Because we would have seen what we think in the research group, more differences if maybe we didn't just make structural changes as we explained that the intervention was, but even relational changes within the staff group. That's one take-home message that we also would like to investigate further in the future. And another question is also, or remark or take-home message is that this should be, and I'm wrapping up, investigated not only with quantitative measures, but also qualitative measures, as these parameters, organizational culture and resistance to change, are difficult to grasp. So we would also need a qualitative measure to sum up with a quantitative measure. That was fast. Thank you.
Perfect. Thank you very much. I really like to learn about your conceptualization of organizational culture and also about the different measurements for resistance to change. Looking at the time, we will continue directly to Alvaro now, but I encourage everyone in the audience to please reach out to Eva, and maybe we have some minutes left in the end, then we can take some more questions. So thank you very much, Eva, and I give the floor to Alvaro. Please take it away.
Hi, everybody. It's a pleasure to be here. Just go ahead and put the first slide so we can go a little bit faster. Okay, the efficacy of lifestyle interventions for diabetes prevention has been well established in clinical trials. However, initiatives aim at translation of these interventions to primary care, so those showing promising results have encountered multiple barriers and challenges that impede actual integration into routine context. For example, difficulties in achieving engagement and commitment among the staff, heavy workload, or lack of incentives hamper this translation. Next slide, please. Interprofessional collaboration between physicians and nurses in a facilitated collaborative process to improve interprofessional interaction and joint decision-making on how the intervention should be implemented seems to be a promising way to improve healthy lifestyle promotion practice, especially as a way to enhance adaptation of interventions to the local context and its determinants. More research is needed, though, to test the effectiveness of different EPC interventions and establish the best procedures for creating successful EPCs, for improving or changing clinical practice and facilitating the implementation of evidence practice. Next, please. The PREDIAS study aims to provide scientific knowledge regarding successful EPC-based interventions by assessing the effectiveness of two procedures for deploying a structured, facilitated collaborative strategy, the PREDIAS implementation strategy, to improve type 2 diabetes prevention in primary care. All centers, headed by a local leader and external facilitator, perform a structured process to model and adapt the intervention and its implementation to the specific context. Specifically, professionals, after receiving training in the clinical intervention, identify areas for improvement based on local needs assessment, collaborative map interventions, actions, flows, procedures, and responsible agents, and finally, standardize the intervention programs after several pilot testing cycles. Next, please. As it can be seen here, centers were randomly allocated to two groups. One applied the strategy globally, promoting the cooperation of health professionals from the beginning, and the other one group performed it sequentially, the one you have on the right, centered first on nurses, who subsequently sought to attain the pragmatic cooperation of physicians. Next slide, please. Well, back off a little bit. Back to one slide before. Yeah, this one. Yeah, here you can see a more detailed strategy. There is a published in some manuscripts. So as you have here in the slide, you have four principal components: strength in the local leadership, training in the clinical intervention of primary care professionals, collaborative planning of the program, and then ongoing and support and facilitation and monitoring of the program deployment. Next. All right. So which are the specific questions that the project wants to answer? First of all, we would like to know which procedure, the sequential one or the global one for engaging professionals and deploying the PREDIAP's implementation strategy will be more effective for increasing the proportion of patients at high risk of type 2 diabetes exposed to the evidence-based clinical intervention to prevent type 2 diabetes, assessment of healthy lifestyles, provision of personal advice, and a prescription of lifestyle change and follow-up. Next, please. So after 12 months of the program, more than 3,000 eligible patients at risk of type 2 diabetes had attended their family physicians at least once, and of these, 419 have been addressed by assessing their healthy lifestyles in both comparisons. The proportion of at-risk patients receiving a personalized prescription of lifestyle change, that is the recommended intensive lifestyle intervention for preventing type 2 diabetes, was slightly higher in the sequential than in the global centers. Next, please. Moreover, a significant between-group difference was observed in the cumulative exposure of patients to healthy lifestyle assessment, advice, and prescriptions over the 12-month program implementation program. Specifically, during the first 8 months, the global group rates did not significantly differ from those obtained by the sequential group. However, during the final 4 months, exposure to lifestyle assessment and to the prescription of lifestyle change was almost 2.5 times more likely in the sequential than in the global centers, respectively. Next, please. The second question was, what is the potential effectiveness of the clinical intervention for changing lifestyle behaviors? I mean, physical activity and fruits and vegetable intake, and whether these conducted procedures for engaging professionals and deploying an implementation strategy modified this effectiveness of the intervention. Next. Next, please. So regarding changes in the level of physical activity, 46.8% of insufficiently active patients at baseline who received a physical activity prescription met the recommended levels of physical activity 12 months after the intervention. Among patients not meeting physical activity recommendations at baseline, who only received assessment and advice, only 12.6% met those recommended levels at 12 months. Concerning fruit and vegetable intake, among people who initially reported insufficient intake, 51.5 met this recommendation at 12 months among those prescribed a healthy diet, and only 16.3% met it among those assessed and advised. Therefore, the probability of meeting the recommended levels of physical activity and fruit and vegetable intake were 4 and 3 times higher after the prescription of lifestyle changes as compared to receiving only the assessment and the provision of advice. The procedure of engagement in an execution of the implementation strategy did not modify any of the effects. Next slide, please. So, which are the conclusions? And well, our results show that the PBS PREDIAP's implementation strategy managed to integrate interventions with proven efficacy and effectiveness in the prevention of type 2 diabetes in clinical practice of primary care. Further, implementation outcomes were somewhat better with a sequential facilitated collaborative process focused on enhanced autonomy and responsibility of nurses, who subsequently seek and pragmatic cooperation of GPs and family physicians. Thanks, that's all for me.
Perfect. Thank you very much for presenting your results. You were also very, very good in your timing.
I know.
Which is perfect for our session because we are tight in time anyway. So if there's any question for Alvaro. I don't see any in the chat yet. Maybe it's also an idea that you can post your contact, all the speakers post your contact information in the chat so people can reach out to you directly, or they can of course also find you in the platform later today.
Okay, I will write down my email there. Thank you.
Yeah, that's perfect. Thank you. Okay, then our next speaker in line is Dr. Joe Day, and I will hand over to her now. So please take it away, Joe.
Great, thank you, Leah, and hi everybody, good afternoon, and thanks for taking the time to listen and attend this session today. It's really great to be able to be with people talking about such a fascinating topic like organisational factors involved in implementation. So I'm just going to be talking about some of our preliminary results from our systematic scoping review about the impact of management and leadership styles when implementing changes in long-term care for older people. So just moving on to a bit of background of this, I work in a collaboration where we work with long-term providers, long-term care providers, and so one of the questions they've had around this has been the role of leadership and management, and that was partly why we came to be doing this particular review. And so just more broadly in background, we know the leader and manager role is considered key for influencing successful implementation of evidence-based interventions and activities, and that's across a range of sectors, and hence why you see it in so many implementation science theories, models and frameworks as well. Pretty aware of those. So focusing more in terms of long-term care, we focus in particular on the manager and leader role. In residential nursing, care homes tend to refer to in England care homes as short, and previous scoping reviews has found the role of the care home manager in particular to be really important and central for making changes for enhancing the lives of people that live in care homes as well as staff that work there as well. So our aim of our scoping review then was to describe the existing research activity around the impact of leadership and management styles on implementing evidence-informed changes. Can you just go back one slide, please? Thanks.
Yeah,
that's great.
I didn't
Thank
even
you.
click.
This is, oh, it might be just be moving because of my slides, so you might have to click a bit, Leah. Yeah, sorry about that. Have fun with that. So in terms of framing our review, we used a scoping review framework, so drawing on Alexi O'Malley, Levac et al. And the Joanna Briggs Institute, Peters et al., and we had an information specialist who helped with our searches, and we did double-blind screening of titles, abstracts and full text by 2 researchers, and we resolved our disagreements by discussion. We then extracted the data from the included papers and synthesizing them as well to a certain extent, and particularly looking at information from each study capturing, and the articles capturing the aims, methods, different settings and contexts, participants, key findings and implications as well. So we were particularly interested in participants or population as care home managers and leaders, and focusing on the concept of leadership management styles and practices on influencing changes. We were predominantly looking at the context of England, but we drew on literature that was from abroad where we thought there might be knowledge gaps in applying this to the context of England. Next slide, please. So in terms of our results, so from our review, on the left-hand side, you can see our preliminary flow diagram based on PRISMA in 2009. And, we started off with over 8,000 records from searches, as well as nearly 500 that we identified through citation chasing. And then through the screening process, we ended up with including 81 articles within our review. So overall, the majority of these 55 referred to 48 research studies. We also located quite a number of opinion pieces, 18, and also 8 articles which describe a particular improvement effort, a programme a process or a model that was about to be implemented in a care home and incorporated leadership and management styles significantly within those efforts. Can I go to the next slide, please? Thank you. So in terms of further results, just focusing on two bits that from our synthesis. Firstly, the kind of methodologies that were used in the research studies in particular. So that was the 48 research studies that we included. And we found quite a few reviews of the literature, and some of these were systematic, some scoping, narrative, also some rapid reviews as well. We also found quite a few evaluations of programme efforts as well, or improvement efforts that had been implemented. And most of these were pre-post type studies, not many randomised control trials within this, a few. And there was also quite a lot of studies exploring the management and leadership styles. Some of these were qualitative, so using methods such as case study, focus groups, observations, ethnography and interview based ones, and also some quantitative studies, so using surveys and questionnaires, and a few that were mixed, so combining qualitative and quantitative research. We also found, not unsurprising, I think, some action research studies as well within our studies. So moving on to the next bit, which is probably the bit we really wanted to focus on, was seeing which management and leadership styles and skills had been most emphasised for positively implementing changes. And so in terms of styles for leadership, particularly found that transformational, distributed, relationship orientated and situated leadership styles in particular were important for positively influencing changes in long-term care. In terms of management, there's a lot of description of a very hands-on, kind of very visible, knowledgeable management styles. Could be encapsulated by that kind of leading by example, was found to be really important for positively implementing evidence-informed practices and changes. And then thinking a bit more about some of the skills that were really highlighted, again, unsurprisingly, I think project and change management skills, but also really important was kind of advocacy skills. Could just flip back one slide, thank you. Was advocacy skills as well. And then also important, it came out was this sharing information and managers being supportive, cascading information, involving residents and staff in the changes, and being responsible and flexible in their approach. And generally they came across as active collaborators within both the community of their particular care home, but also more widely in their profession as well. So next slide, please. So just some reflections and implications from our review at this stage. So firstly, we've sort of been, as I just mentioned, identified some styles and skills that could impact positively on implementing changes in long-term care homes in particular. And we really highlighted that it's important for leaders and managers to share their learning and collaborate and support each other. Highlights the importance of making changes through things like networks and communities of practice being particularly relevant. From our articles, many of the articles noted it was really difficult to and challenging to rigorously research leadership and management in care homes context. Many uncontrollable factors. I think the pandemic was an example of an incredibly uncontrollable factor we've had to deal with, and a very sort of shifting organisational local context as well as a broader, wider context as well. In terms of limitations of our review, again, you can flip back one, thank you. In terms of limitations of our review, we haven't involved a stakeholder group throughout. I mean, obviously this was generated from our collaborations with long-term care providers, but we will be sense checking our findings with back with our collaborators on our other projects and sense checking them. And we're also identified sort of further knowledge gaps around how leadership and management styles, skills, knowledge, values and attitudes and contexts all combine when trying to implement changes in this context. So next slide, please. So I think, hopefully that gives you a bit of a feel for where we've got to with our review, and just a couple of discussion points really just to think about and take away is whether these kind of findings resonate more broadly when trying to implement evidence-informed changes in different sectors for managers and leaders. And then also a question around how can support for managers and leaders to implement evidence-informed changes be further researched and enhanced to improve services and people's lives. Next slide, please. And I'd just like to say thank you very much for listening today. There's some of my details, I'll put them in the chat as well, but if you've got any questions or comments, then I'd love you to get in touch. Thank you very much.
Perfect, thank you very much. I was thinking when you were presenting, it would be interesting to actually get the sense from the audience of if they would find your results surprising or if they would find them expectable. And there is actually one question in the chat for you, which is, isn't healthcare known for the kind of styles and skills you mentioned to be emphasized? What are styles and skills also seen in the studies which do not impact change?
Yeah, so yeah, I think this follows. So some of my research is about leaders and managers within healthcare settings as well. And I think there was quite similar. I think transformational and relational approaches to leadership are much more emphasized in long-term care than as much as I think that's similar, but really that adaptive style I think is really important. I think those are in healthcare system as well as long-term care system. Skills which don't change, probably that very top-down authoritative leadership style. So yeah.
Cool. Okay, thank you very much. And thank you, Karian, for your question. So sometimes the slides are moving without me moving them, and I don't know why, but we try to keep sane. So we stay in the UK and we will give the floor to Dr. Tom Jefford.
Hi, good afternoon. Next slide, please. So this is my doctoral study, and I have been involved in multi-systemic therapy for a long time, but I was certainly interested in why some teams are sustained and some are not. And I wanted to learn both from successful sites and also unsuccessful sites. So in 2008, there were 10 new MST teams that were set up with funding. These are the teams that eventually formed the basis of the START RCT trial into MST in the UK. But this was unconnected. My research was unconnected to that. So I followed these services up 7 years later. One had closed 2 years, one had closed at 5 years. One had been sustained and actually was considerably expanded to a number of other MST teams as well. So my research questions were really concerning why were the outcomes so different when the initial setups were so similar, in that they all got to the starting line, having opted into this program, given organisational support and strategic agreement. They all had the same funding, they all had the same templated job descriptions and the same support from MST services. So what happened and what can we learn from the very different outcomes experienced in those 3 different areas? Next slide, please. So I took a grounded theory approach. This was in-depth participant interviews across 3 authorities. I also had one interview with the national program lead for MST and went through a process of coding and synthesis to provide new theoretical concepts. Next slide, please. So my main findings were really to come up with 2 different environmental conditions. The first I called the high collaborative environment. And by that, I mean a situation in which the local authority leadership and partner agency leadership managed and facilitated in an active way the operational space for the intervention to be successfully embedded and to be sustained for the long term. It's a bit like trying to hold the lift doors open to allow people to walk through without the lift doors closing, or perhaps better thought of as if you transplant a kidney into someone through a transplant surgery, how do you stop the body from killing the transplanted organ? So there was a significant value-driven level of support for the new services. It resonated with the social work values at the time, with the prevailing management and leadership culture, and enabled the services to overcome the blocks and obstacles to mobilisation and to really begin to find its place within the local authority children's services setting. I think it's important to mention that this was an active process that included both leadership at the practitioner level, first line operational level, and also strategic management. So we're thinking about the micro and the macro here, and the way in which the services connected into the organizational culture, and actually began to become celebrated as part of the organizational culture. By contrast, though, the hostile environment is really one of continuous threat and strategic change, where the intervention feels poorly placed and out of step with the children's services. It's a very difficult thing to kind of understand, but one of the services that had been in place for 5 years had initially had a very positive start, and it was seen as an agent for change. But because the local authority had a number of changes of strategic leadership, the web of support that held it in place became diminished over time until it was weakened to the point at which it was no longer seen as relevant. It was not celebrated or supported in any way at all. So there was then a very small number of people, actually largely the participants who were managing the team itself, who were hanging on, hopeful that a change in leadership would swing in their direction and enable the environment to change to a more positive way, but continually under threat. And with each new change of leader, the leader would come in and say, what are the contracts that I can get out of? How can I make short-term change? What can we stop doing? And this is my idea of how children's services should be run. So there was a significant level of threat that was ever present, and certainly made the services feel extremely vulnerable all of the time. Next slide, please. The second major finding really was about leadership support for the notion of leadership for implementation as described by Aaron's. The leadership which enabled the services to be successful was attentive, relational, collaborative, and perseverant, but it was also values-led. And so consistent leadership at the MST steering group in the service that was sustained and expanded was identified as absolutely vital. It was where differences could be put aside and strategic objectives could be drawn together in service of the operational model being facilitated to do the best that it could. And there was certainly a lot of hard work that took place at that strategic steering group, but it's also where trust, confidence, and a shared sense of identity for the service was both preserved and maintained, and indeed passed on to new participants who joined that group as part of their kind of cultural induction into that local service. Next slide, please. So some of the lessons for practice are about maintaining and refreshing leadership at the steering group. In one of the services that closed at 5 years, the steering group had initially been led by the chief executive of the organization. It then went to a strategic director. It then went to an operational manager, until eventually the MST supervisor herself was chairing the steering group that was supposed to be managing and supporting her own service. So you can see that the diminishing of the strategic relationship actually made a massive difference. One of my interviewees described a toxic trio, which can be described as a change of leadership, a change of supervisor, and then funding challenges. And my guess is that the most strong sort of services could probably survive 2 of those instances co-occurring, but 3 would overwhelm even the strongest of services. And there's definitely something about the point at which a supervisor changes, which is seen as almost requiring the setting to make a recommitment to whether they want the whole of that service there at all, because it's a pivotal appointment to make, and one that really sets out whether this service is going to continue or not. Lots of the services had anticipated that the START trial would provide evidence of effectiveness, but actually that was very much delayed. And even then, the evidence of effectiveness that was presented was often data that the local authorities found difficult to interpret. Local authorities really wanted narratives, they wanted stories, they didn't really want to see outcome data and didn't really understand what that could do. I think that the teams worked out that they needed to build alliances and trails of support in good times as well as bad. partner agency support is absolutely vital. And if it wasn't supported with information and stories and encouraging people as to why they should support this service, actually, when the bad day came, when the funding crisis came, that support wasn't there to say, no, this is a service or value, and I know that it does these things and we should do it. So taking responsibility for informing strategic leadership of value and outcomes is absolutely key. And like any business, if the phone goes quiet in the sales office, something's gone wrong. So you have to be attentive to the referral pipeline and see the quality of the referrals. They need to be the right referrals, not ones that are seeking to break the system, nor ones that are actually not really going to see the full benefit of the intervention as is described. And finally, I would say plan for the predictable crisis and turnover of key staff. Services seemed surprised when staff left and seemed to think that because they had 3 years funding, that the services would simply have the exact same staff for the entire period, and turnover was often experienced as a crisis that led to the underpinning of the service feeling much more vulnerable. Next slide, please. And that's it.
Perfect. Right in time. Thank you very much, Tom. So are there any questions? There were some questions popping up for Alvaro a bit after his talk, so maybe questions are still coming in for Tom. If you don't have a question, feel also free to share your thoughts about the presentations, or if you can relate to the findings, or if you have similar experiences in your work, feel free to do that. We are moving now to Switzerland, and we will give the floor to Tekla, who will give the last presentation of today. So thank you, Tom, and welcome, Tekla.
Thank you, Leah, and good afternoon to everyone. Today we already heard about pain management and also about leadership in long-term care. So I'm very glad to wrap up this session because I will talk about both of these topics again. And I would like to present to you some excerpt from our process evaluation of the PROQUAS study. Next slide, please. So PROQUAS was an implementation science study which we conducted from 2015 to 2019. And the overall aim was to develop and implement a pain management intervention and to improve pain in nursing home residents in a Swiss nursing home group. Next, please. And the overall project can be divided into two parts. The first part comprised contextual analysis, where we collected quantitative and qualitative information concerning the context and also potential barriers and facilitators to implementation. And we used this knowledge in the second part to develop the intervention and also to tailor our implementation strategies, which we then tested in a hybrid trial. So we looked simultaneously at the implementation, but also at the effectiveness. And with regard to the effectiveness, we could see a quite positive effect. So the pain was improving in the residents. So this was really good. But for this study, you can click now, the aim is really to look into the implementation strategies with regard to the implementation outcome and potential barriers and facilitators. Next slide. So what am I actually talking about? In PROQUAS, we developed this pain management guideline, which was adapted from international recommendations. So for example, the American Geriatric Society. And next, we used these implementation strategies, which were derived from the contextual analysis. And I will focus on two of them in specific. So first of all, we introduced some so-called pain champions. These are registered nurses who received a specific training on pain management. So they were supposed to really guide the care workers to provide support and educational sessions to all care workers. And the second central strategy were training workshops for all care workers. And if I say all care workers, I'm highlighting this because in the Swiss nursing home context, it's important to think about the staff structure. So most of the care is being done by healthcare aides, nursing aides, or nursing assistant, and they don't have a professional training in nursing. And the other part of the care is being done by registered nurses and licensed practical nurses who had like 2 to 3 or more years of a professional training. Right. In addition to this, we also conducted continuous meeting with the nursing home leadership and also adapted the nursing home documentation software for our study. Next slide, please. So just for this very short excerpt of the process evaluation, we had a mixed method approach, and we used the quantitative data from care worker surveys. We asked care workers if they experienced a situation that would require them to use some elements of the guideline. And then we asked if they actually applied this guideline to the situation. And this is our guideline adoption in this case. And for the qualitative data, we conducted focus groups with care workers, again, separately the healthcare aides from the professional nurses. And in the next slide, you will see the results of the adoption. And I don't want to focus on these numbers too much because you can see the numbers are not really great. They are rather somewhere mediocre. But we were really fascinated about these numbers because we have seen a huge effect actually of our intervention on the residents. So we were wondering how come if the adoption is so low, it might be due to the self-report, or what else could be the reason for this. That's why we also conducted the qualitative work, which we will see in the next slide. And what we found out was that our workshops, our implementation strategies were really helpful to sensitize the care workers towards the pain in residence. So they were really more aware of the pain and would ask more questions. So if they see a resident walking around looking a little strange this day, they would really go there and ask, are you in pain? Is everything okay? Which they did not do too much before. Also, the workshops were really helpful for them to get motivated again to ask and go back after, for example, providing medication to a resident and ask again if this was helpful at all. However, we could also see some huge differences with regard to the professional groups. If you could click, please. Thanks. So on the one hand, we have the more professional trained nurses, so the registered and licensed practical nurses. They were in general rather skeptical. They felt like, oh, we know everything already and we do everything all right. We know the guideline by heart and we live it basically. However, they also admitted that the workshop was helpful to reduce some unnecessary pain medication in residents. On the other hand, in the nursing assistants, if you could click, they were really glad about the workshops and about the whole project idea because they finally felt empowerment for their role in pain management. They received some skills and they could finally ask the resident to really assess the pain. And also everybody recognized that they would react much faster upon resident concerns with regard to pain. Go to the next slide, please. And the pain champions, they were really central because everybody knew them during the study. And in general, the idea was perceived as very good, that there is someone responsible for the topic of pain. However, again, we see some discrepancies between the professional groups. If you could click. In general, the acceptance of the pain champion would vary between different pain champions. So some of them had a more formal role, so being a nurse manager, for example, compared to a usual, like a general ward nurse. And also the training of the pain champion was important for this. What also can be said that they all recognized that the pain champion was really helpful to facilitate the medication management with the physicians. You click again. And again, the nursing assistants were really positive. They felt highly supported and thought it was a great idea to finally have someone to receive some specific supervision with regard to pain management. Go to the next slide, please. And overall for this study, the conclusions, we saw it's really important to have this continuous commitment of the implementation facilitators. And it's also important to think about the different professional groups that are involved and that they might have different needs with regard to implementation, and this role should really act differently with regard to the professional groups. What we also saw, as other already talked about today, is that leadership support is essential. And also, if there are any changes, this continuous commitment of the pain champions could really help to keep the momentum going, though the leadership might change. And I think this is important to think for the next future undertaking. And then the next slide, please. And thank you a lot for your attention.
Perfect. Thank you a lot, Tekla. Really interesting to also learn about the different perspectives of the different stakeholders in your study. If you have any question for Tekla, please put it in the chat. We have 4 more minutes left until our room will close. So I'm just going back to 2 questions which came in for Alvaro. So there's a question from Monique, and she's asking what might be an explanation for the somewhat better implementation outcomes in the sequential arm of your study. Would you like to answer that briefly?
Yes, and the other question I think is the same. Well, there are several reasons. First, because nurses are the main agents responsible for provision of intensive healthy lifestyle promotion actions within primary care. So that's one important thing. And second, and it's related to this, because nurses within the sequential strategy had autonomously consolidated implementation of the clinical intervention, the clinical program at the level of its establishment, and this made them to feel and act more responsibly within continuing with the implementation of the prevention intervention program during the whole implementation period. So due to these 2 factors, they were more effective in organizing that pragmatic cooperation with family physicians to maximize the efficiency of intervention programs, flows, and procedures in a context of clear differentiations of roles and tasks. In contrast, within the global strategy, the responsibility of implementing the program was more diluted and went down faster, obtaining worse results. In any of the cases, if you want to see more results related to the study, they're going to be published this week, I think, in the Implementation Science journal. So you will be able to check all the results in that publication briefly. I mean, in this week, probably.
Brilliant. Cool. Thank you. So if you can share that publication with us, then that would be perfect. And thank you for the question. So we have probably a minute left. So Tekla, there's a question for you. For a new implementation project, would you again work with champions? We need a very quick answer.
Yes, go for it. I think it's a great strategy. It's about considering who the champion should be and how you implement the champion. And you need the leadership to support the champion. Otherwise, he or she cannot be really effective in his or her work. I think.
Cool. Thank you. So there's another question coming in from Nele, and I'm also for Tekla, and I need to now connect Tekla and Nele to meet up in the network lounge after this meeting to discuss this question, because we need to close this session now, or it will close us basically. So thank you very much for the fantastic flash talks today. Thank you to our 5 speakers. Thank you to the audience. We were quite a big crowd, so lots of interest in this topic. I really enjoyed the session, and I wish you a great event today with the last keynote and tomorrow again. So enjoy David Chambers and see you all tomorrow.